Manoj Srivastava and Dr. Monica to give memento to our learned speaker, Dr. Akshay Pradhan, sir. So, Heart India have decided this year to start a new award from this year. That award is Lifetime Achievement Award. And for this year, we have selected our celebrity cardiologist, Dr. P.R. Sinha, sir, for Lifetime Achievement Award. And sir is one of the most famous cardiologists in Eastern Uttar Pradesh. He did MBBS, MD, DM from BHU. He is a Dr. D.P. Basu Best Award Paper in Cardiology, API 1996. He has been conferred Dr. S.C. Jain, Oration OPSCSI, Lucknow. He has almost all fellowship of American College of Cardiology, European Society of Cardiology, and Fellow of Cardiology Society of India 2005, 2018, Indian College of Cardiology. He has more than 25 papers in all index journals. One of his papers on pericardial effusion have been cited very much high. So I request Dr. Akshay Pradhan and Dr. M.K. Srivastava and Dr. B.K. Singh, sir, to confer Lifetime Achievement Award to Dr. P.R. Sinha, sir, on the behalf of Heart India. Thank you, sir, for accepting the award. Now I call upon Dr. Rohit Tiwari, sir. Dr. Rohit Tiwari contribution to the growth of Heart India Journal is unparalleled. And he is the only reviewer. He reviewed almost all articles within 5 days when he allot him. So for his contribution to Heart India, we are awarding him the best reviewer award of Heart India for decade, because almost 11 years have become the Heart India. So now I request Dr. P.R. Sinha, sir, and Dr. M.K. Srivastava, sir, to give best reviewer award to the Dr. Rohit Tiwari, sir. Now I again request Dr. P.R. Sinha, sir, to give memento to Dr. M.K. Srivastava, sir. Sir is always encouraging to do more and more activity. Now I am requesting Dr. B.K. Singh, sir, to give memento to Dr. Monica Gupta, ma'am. Thank you, sir. So for next session, for chairing the session, now I am inviting Dr. B.K. Singh, sir, to please come on the dais, and Dr. H.D. Singh, sir, for chairing the session, please come on the dais, and Dr. S.N. Rai, sir, come on the dais. And as we are running short of time, I request all the speakers to be on time and try to finish their talk within 15 minutes. So cut short and be little fast. Over to the chairperson.
Now we have a second session of the conference, and the first lecture on 18 obstructory normal heart. And the speaker is Dr. Asutosh Kumar. He is DM Cardiology, Care Hospital, Hyderabad. Is it here?
Uh, Thank you, Dr. Alok, and it is a great opportunity to come to Banaras because I did my DM from here on, MD from here, and coming to Banaras is as such is a great moment for me. So I never lose the opportunity, and I think it is fifth or sixth opportunity I am taking to come. And as Dr. Rohit, who is my senior, and he was the guiding person when I was doing my MD, he was doing DM, and we both are his third year, his first year, I am a first year. So it was a good, great association with him, and his sense of humor was always a thing which I learned from him. And Dr. Alok, as usual, academics from that time, my senior also. So coming to the topic, which was Dr. Rohit was saying that it should fear, it give a lot of difficulty. I will try my best to make it simplified. No doubt, whenever ventricular tachycardia issue comes, the diagnosis itself is because it is a matter of life and death. If you are missing, sometimes the patient will die. And which patient how to approach the. There are three ECGs I am just showing it, and all are in the patient who are having normal heart. Means previously they are not having any heart disease, and they are referred to us. And these three ECG, if you can see, all are having the VT only, but different morphology. So whenever I will not say VT, before making a diagnosis of VT, we should be clear white QRS tachycardia or that should be labeled, because sometimes we are not able to make the diagnosis whether it's a VT or SVT with aberration, or we are having some electrolyte imbalance leading to the white QRS. So first, foremost, see the hemodynamics, convert it, and second, you should try to see whether it is a monomorphic versus polymorphic, because this question is going to make a lot of difference whether how to approach and what are the things to be seen. After that, the next question comes regarding the topic proper, that is the structural heart disease, whether the patient is having normal heart or abnormal heart. So the principle of management of any VT starts from the whether we have to go for drug, device or ablations. It is based on these three pillars. And if we are coming for the structural heart disease versus non-structural, there is always a question what the structural heart disease is. So if a patient is having coronary artery disease, LV dysfunction, or patient is having cardiomyopathies, or patient is already having myocardial infarction and scar, so those type of patients we say that the patient is having structural heart disease. But sometimes even the subtle disease is ongoing and we are not able to make any diagnosis related to the structural, and we have to do ECG echo, which most of the time turn out to be normal, on which we most of the time probably say that the patient is having structurally normal heart. But the surprises come when we are doing the cardiac MRI, where a lot of information comes. Sometimes the scars are there which we have learned, and it may be a scar related VT. So cardiac MRI is the final tool to establish whether the patient is having structural heart disease or not. But as we are practicing in any city, it is important that ECG echo are more than enough, and if you are doing angiography and it is turned out to be normal, it can be taken as a structurally normal heart. If we are going to classify, the most important thing which we are looking as a approach point of view, whether we are dealing with the idiopathic VT, in which we are having three common variants: the outflow VT, fascicular VT, and papillary muscle VT. In this papillary muscle or fascicular VT, sometimes it is only the mechanism and the patient entity. Otherwise, both are having the similar morphology on the ECG, very difficult to differentiate also. And there is a second, what is called arrhythmic syndromes like long QT, short QT, CPVT, and Brugada syndrome. So there the heart will be always normal, and most of the time they will say that patient was having syncope, we have gone for the ECG, echo, TMT, everything was normal, and we are not knowing why the patient is having syncope. So this type of patient fall in this primary arrhythmic, means syncope, sudden death, presentations are more common in primary arrhythmic syndrome. While the patient of outflow and fascicular VT will be having palpitations, even though patient is having VT, they may be coming with a palpitation, sometimes sweating, sometimes abnormal other behaviors. And the management is medical therapy, means antiarrhythmic. Sometimes we have to send the patient for the ablation as a primary therapy. And sometimes the patient, if they have recovered, we advise for the device therapy. So these are three pillars for the VT ablations, for the VT treatment related to the structural heart disease. So how to decide which type of patient we have to take for the arrhythmia management? So VT with normal heart, what we have to label, what I was saying, that outflow tract and fascicular VT. If these patients are there, the cardiac MRI, ECG we have to do, echo we have to do, and after that we have to establish. If the patient is outflow and fascicular, these are the VTs in which you just do the ablation, it is cured. Most of the time it is cured and there is no need of any medicines. If patient is not comfortable for going for ablation, put the patient in the drugs, antiarrhythmic drug starting from beta blocker initially, later on switch over to flecainamide, or if the patient is having structural heart disease, that I will come later on, that amiodarone can be given. But if the patient is having channelopathies like Brugada syndrome, long QT, short QT, or idiopathic ventricular fibrillation, anytime it has been documented, there the role of ICD comes. Means if the patient is having any syncope or sudden death has happened in the family, they should opt the implantable cardiac defibrillator. So these are two treatment policy. But when we are writing a diagnosis of structural heart disease, means coronary artery disease, LV dysfunction, cardiomyopathy, HCM, ARVD, then the role of ablation doesn't come first. The first is device followed by ablation. So the principle totally changes when we are writing. That's why we are writing structural heart disease means ablation and drug, ablation and ICDs. And if patient is not ready, then you should go for the drug treatment. So coming to the first patient, this was been referred, and she is a 16-year-old girl who has been referred by our interventional colleague. He told me that patient is not affordable. I think he is having some loss of consciousness. PR is short. Why don't you do a EP study? And in our state, we are having Arogyasri, so everything free of cost. You can do the EP study. So I was a bit hesitant seeing the ECG because the complaints was the history. What makes the difference? That she was saying that on and off when she is playing since the age of 5 years, she was falling, she fell down and she will recover. This was the complaint. And she was taking anti-epileptic drug for last 10 years. Gardinal she was taking. But initially there was some relief, later on there was no relief, and later on the patient was having on and off complaint, and she was referred to us for the same complaint. By seeing the PR segment, I thought there is no doubt the doubt of pre-excitation may be there. But why not to go for the, if the PR is increasing, we can do the TMT. So the role of TMT in electrophysiology comes to see whether the patient is having pre-excitation which is increasing, delta waves is coming, and we did the TMT. And if you can see the TMT, the VPC start coming, it is increases, and later on the patient start having giddiness. And finally, what is called the classical bidirectional VT has been documented. So even just doing the TMT, the patient was having the same giddiness. We stopped, and finally it is clearly recovered, and finally the patient was diagnosed also. And what is written in the book, this is the only disease in which we can say by doing the TMT you can establish. So TMT, if the heart rate is between 100 to 126, the VPC is, and after 126, it is written in the Brown world, and we have replicated the same thing on the patient also. After 126, the bidirectional VT started, and patient is having cover. At 100 to 120, VPC will come, and after that bidirectional VT, which was very classical for this CPVT. We put the patient on the propranolol with flecainamide, and after that the patient is almost, for last 4 years, there is no episodes. So she is doing fine on the medicine only. And this is the one drug which we prefer for giving. Second is this is a case of 46-year-old male, recurrent palpitation, failed on adenosine. And this is a common call we get from the ER. Sir, the patient adenosine de diya, kuch nahi ho raha hai, what to do next? And whenever we are getting a QRS which is not very wide, it is in between, and if you are seeing a RBV with left axis deviation, always and always keep the possibility of fascicular VT. So this is one of the VT in which the morphology will be somewhat like PSVT, and adenosine will be refractory. So when you are giving adenosine, in a patient with RBB type of morphology, if it is not reporting, keep on back of the mind, it may be a VT. And here, if you are giving calcium channel blocker, the patient will revert, or sometimes beta blocker also. And after conversion, the patient was having the T-wave inversion. Since he is a 46-year-old male, the patient was underwent the echo, angiograph, everything done. Seeing the T-wave inversion, everybody want to jump for the intervention that is a VT. So we want to put the stent. And finally, everything was normal. We did the EP study. EP study wise, the patient was having fascicular VT, and after ablation, the things was totally cured. There is no episodes, and it is one of the curable type of ventricular tachycardia. If the patient is not ready for going for procedure or not affordable, put the patient on the calcium channel blocker, and calaptin is one of the wonderful drug. It responds like anything. So it is a re-entry VT and resistant to adenosine and well respond to calcium channel blockers. Again, 25-year-old boy, recurrent loss of consciousness, no history of family history, was negative for sudden cardiac death. And this is the first ECG. We were not knowing how to approach, but there was some suspicion. If you can see the first V1, V3 lead, there are what you call classical. Initially, the first ECG was not showing. So we have taken the ECG in the one intercostal above, and you can see the classical type 1 Brugada pattern has been replicated. So importance of taking the ECGs, all ECGs and channelopathies, the ECGs will be changing. Means the same person, the ECG of over time, there will be temporal changes. What the classical Brugada pattern or long QT may not be coming in the first ECG, but over the time, it may be the second or third ECG may be having the classical pattern. So it is very important to see all the battery of ECGs or the patient is carrying and see whether the patient is having or not. So channelopathy sometimes mislead by if we are only banking on one ECG. And this patient was put on the AICD and patient was discharged. He was doing fine, though he is very young, but 2 episodes was detected after that. This is the fourth case. This is a patient. He is having around 27%, 24% of VPC burden, and it was refractory to medicines. We have given first beta blocker, later on flecainamide. Not responded. Somebody has put a calcium. Patient has been put on the cardron, amidron, but it was reduced, not totally cut. But patient, since they were having the what you call government scheme, and they asked that you should go for the ablation. This patient, what you call VPC burden was more than 20, so we took, and this patient was having VPC which is coming from the left cusp, means just near the coronary. So by the retrograde method, we went and ablated, and now you can see doing the angiography, we have put the catheter in the coronary sinus, and left coronary sinus it was coming, and after ablation it was totally, so there was no VPCs and there is no need of any medicines. But it is a challenging case for us because patient was bit young and there was no VPC, 0.5%. This is a recently, means I think 7 days back only we have ablated, 23-year-old boy, recurrent palpitation. And the challenge was that his LV dysfunction was there. So 3 months back we have seen, we have put on the beta blocker, later on flecainamide, same. And it was not responding. Again, we have taken the patient. And ECG was a very, means if you are able to see the ECG, it is giving a lot of information. So the important thing what is in this patient, that V1, if you are seeing what you call outflow type VT and AVR, AVL reversal are there, means AVR and AVL are having a different morphology, discordant. It favors that it is coming somewhere from the inflow, what we call as his area. So that we have anticipated, and we took the patient in the, and his burden was around 20% even after medicines. His LV function was around 40%, and you can see the 2 catheters, if you are able to see, these 2 catheters, one is sitting at his, and this is the ablation catheter which is sitting at the location from where we have ablated. So this is a parahesian VPCs which was causing LV dysfunction. We have ablated, and after that the patient developed RBB, right bundle branch block was there, but there is, we are expecting over time it will recover, but patient is now asymptomatic. We have to see over time how the LV function improves. So in the VPCs, more than 20% is always an indication. If the patient is symptomatic, you can take it, ablate it, and take off from the medicines. And this is the case, I think most of the people will be seeing. The patient is having diarrhea, she was having syncope, and referred to from outside that whatever we have given 20 shock, the VT is not reverting, what to do next. And these are the challenging cases where you have to take the history, why the patient is not responding on amiodarone, or the patient, what medicine has taken. So whenever somebody say that patient is not reverting on amiodarone, I initially see the patient's QRS as well as the QT interval. If it is prolonged, it is the lesson that in QT prolongation, we should never give amiodarone. Otherwise, your one shock is going to convert into 10 shocks. Means 10 times more you have to give the shock to revert it. It is a polymorphic VT which will start running, and whatever shock you give, the patient will have the VT. So QT prolongation anywhere means anywhere you want to give amiodarone, well and good. But before giving amiodarone, check the patient QT. If the patient is having narrow QRS before the VT and the QT is crossing 500, it is better not to give. Give other, you can give Xylocard, you can give Mexiletin, other drugs, but not amiodarone. If you have given amiodarone, then be ready that the patient is going to develop the polymorphic VT, for which you have to pace the patient and put the patient on the Xylocard for time being, to tide over the situation. So this was the lesson for this case. So we put the patient on temporary, later on we pace the patient at around 90 to 100, and after that it has reverted. If you are not able to do that one and the situation, the patient is in the periphery, correct the potassium, keep the potassium at around 4.5 to 5, means keep on the higher level. Don't check the magnesium, start giving the magnesium, and up to 12 gram you can give in 24 hours if the patient is having a good renal function. And if you are having opportunity to pace the patient, it will revert. So polymorphic VT, what is the most dangerous of all the VT, because it doesn't give the time. And there are two roles. If the patient is having if the patient is having prolonged QT, we are having already the treatment what I have discussed. But if the patient is not having the prolonged QT, which is happening in the two important situations. One, what Dr. Rohit was saying, the patient is coming with the VT storm. So patient of MI will present with polymorphic VT if they have come in the initial SAR, and there if you put a stent, the patient's VT will be off, means totally immediately will go. So there only one way to stop the VT, that is a stenting. If you are not doing a stenting, whatever you give the drug, it will not revert. And we have seen few cases in which only a single vessels were blocked. The time we pass the wire, put the balloon, VT has gone. But 25 shock has been given, the patient was not reverting. So that is the role of stenting as an antiarrhythmic in that situation. And other than, there are some condition what is called channelopathies as well as J-wave syndrome. Though it is more discussed in the book, I have not come across those type of cases. But if you are facing those type of patient where the QT is normal and patient is having VPCs, very early VPCs, they are the culprit in which the VF develop. And for that, J-wave syndrome we call as, in this there are two entities, that is, one is Brugada syndrome and second is malignant repolarization syndrome. I will not go into detail. So this is the final thing. EP study RF ablation if the patient is in idiopathic VT, and if the patient is having structural heart disease, ICD is the primary therapy. If the patient is having ischemic cardiomyopathy, drug and ablation. And finally, if the patient is having primary arrhythmia, then drug and ICD will be. So variant of polymorphic versus monomorphic, QT, channelopathy marker we have to see, how is the ejection fraction, and finally the coronary artery HCM that we have to see. Quinidine, one of the wonderful drug, but we are not having in India. So this, wherever the J-wave syndrome like Brugada syndrome, repolarization syndrome, there we can use these medicines. And this is the final message, that if you are getting a monomorphic VT with structural heart disease, amiodarone is the drug of choice. If you are not having that, then you are having Mexiletin. But if the patient is having structural heart disease with polymorphic VT, you are having very fixed choices. So ischemic heart disease, lidocaine is available in our country, that can be given, or stenting if the patient has not been stented in that scenario. And flecainamide is one of the drug of choice for CPVT, and important because sometimes the patient is pregnant, so or patient is like that girl 16 years, she may go in the pregnancy. So this drug can be given during the pregnancy also. So thank you so much for patient hearing, and if any question I will.